chairs have had a slight issue joining us for the moment, but hopefully they'll be along with us shortly. So welcome to the UKKA CKD group and the webinar this evening, which is going to focus on two main issues, both centered around chronic kidney disease. The first being inequalities, and particularly the changes in the NICE guidelines in relation to ethnicity. And the second part will be around the changes in referral guidelines and the kidney failure risk equation. If you have any questions, please add them to the Q&A tab, and we'll run through the questions towards the end. And that's everything to start off with. So if I'm going to introduce Rageshri, who is going to be talking about facing up to inequalities in care for chronic kidney disease, and I'll look forward to having a discussion with her towards the end of the talk. Thank you.
Great, thank you so much for the introduction. I'm just going to share my slides. So hopefully you can all see my slides. So you may be wondering why I'm not a kidney doctor, but I'm giving this talk. But essentially, I'm Rageshri. I'm one of the HIV consultants based in London. And a lot of my work and research is around health inequalities. So I'm here today to really provide an overview of health inequalities in the UK with a nod to kidney care. So I don't think we can really start any talk at the moment without talking about COVID. And I think the conversation around health inequalities has really highlighted that health inequalities are a big issue with regards to COVID. And certainly with COVID, we have seen big inequalities between different patient groups. And I think the author Damien Barr describes this very well when he says that we're in the same storm, but we're not in the same boat. So we do know with regards to COVID, for example, that it is people living in the most deprived areas in England and Wales who are much more likely to die. And that's due to an increased risk of exposure, working in precarious, low-paid manual jobs, in caring, retail and services where they're really face-to-face with people, and living in overcrowded, poor quality housing with densely populated areas. And also due to their increased risk of poor outcomes. So we know people from deprived areas are more likely to have pre-existing illness, which can lead to poor COVID outcomes and also poor access to healthcare. And before COVID-19, life expectancy had already stalled in the poorest areas of England and Wales, particularly for women. And we know from Michael Marmot's work, 10 years of austerity politics, particularly in the most deprived areas, led to increasing food insecurity, child poverty and homelessness, which has all caused increasing inequality with health outcomes. So what are health inequalities? Well, they are avoidable, unfair and systematic differences in health between different groups of people. And there are inequalities with regards to health status. So for example, life expectancy and prevalence of health conditions. There's inequalities in access to care, so availability of treatments, for example, inequalities with regards to quality and experience of care, inequalities with regards to behavioural risks between groups. So for example, higher smoking rates in some groups of people, and also the wider determinants of health. And I'm going to talk about them more first of all. So this shows very clearly that we always need to think about the causes behind the causes. So yes, we know that obesity is a cause of cancer, but as this graffiti artist has said, what are the causes of obesity? They're quite often poverty, inequality and austerity. And when we think about the social determinants of health, the World Health Organization says that they are the non-medical factors that influence health outcomes. So they're the conditions in which people are born, grow, work, live and age, and also the widest set of forces and systems shaping the conditions of daily life. And these include economic policies and systems, developmental agendas, social norms, social policies and political systems. And just listed on the side are some of the social determinants of health. But I think it's important we think about what's behind the social determinants of health as well. And really the root of them is an inequality in power. So where we stand in the social hierarchy affects our chances of good health. So essentially it's the causes behind the causes behind the causes. For example, groups that experience structural racism or gender inequity. And if we think about racial health inequalities as an example, I'm not going to go through this long list, but you can see that there are racial health inequalities in most aspects of physical and mental health in the UK compared to white British people. And I know Kate's going to be talking about ethnicity after me. So when we look specifically at health inequalities in kidney health in the UK, we know there are inequalities between different groups. So people from socially disadvantaged backgrounds have a higher burden of kidney disease and are more likely to start dialysis. We know that more women have kidney disease, yet more men start dialysis. And there are ethnic inequalities with regards to starting dialysis and also receiving a kidney transplant. And these were looked at in a 2018 inequality report, which I've just referenced at the bottom there. So looking at some of those aspects in which we see those inequalities and reasons for them, some of them are to do with access to care. So when we think about our services, we really need to question, is it our services that are hard to reach, not is it the populations that we serve hard to reach? So for example, in terms of health promotion, is our promotion reaching the right people in the right places in the right way? Are we working with our primary care colleagues in other specialties on referral pathways to make sure they know who to refer and when to refer? And making sure that people can navigate the NHS, so particularly migrants who have been put off from accessing NHS care due to worries about the hostile environment. So making sure they're aware of their entitlements to NHS care, such as getting a GP, for example. And what about quality and experience of care? Well, again, looking at your service and thinking, do we have interpreters? Do we have information available in different languages? Are we flexible with our appointments? So do we offer a mix of virtual and face-to-face appointments so that people who experience digital poverty can come into appointment if they don't have access to a phone or the internet? And what about clinic timings? You know, if we've got patients who have a lot of childcare responsibilities, are they able to attend clinic appointments at a different time of day, for example, when they're not in the school run? And really thinking about the impact of prejudice and discrimination on certain patient groups. So thinking about our individual prejudice and discrimination, so being aware of our own implicit bias. And of course, we do all have implicit bias because we're all raised in the same society, so we all rely on stereotypes that we've been brought up with. So that's really a matter of individual reflection, so thinking about how our own biases may impact on our care. But also we can think about policies that we can implement that may overcome individual bias. So for example, in my specialty of HIV, we now have set up in many areas opt-out testing for HIV for anyone having blood tests in primary care or in A&E. So instead of the person saying, is this person likely to have HIV, shall I do a test? They're offered to everyone. So taking away that individual decision and that bias. And the other thing about impacts of prejudice and discrimination is that people can end up being very mistrustful of medical care services. And this can be frustrating when you're working in a healthcare service, but we need to understand that it's often a reasonable response to poor experiences of care in the past. So where people do have mistrust, accepting that it's a reasonable response and making sure that we're having the right conversations so that we can start to engender trust with our patients. And then finally, thinking about knowledge production and leadership. So we need to make sure that we can address knowledge gaps to reduce inequalities. So funding research to understand and address barriers to care. So really thinking about what works. Making sure we are asking the right questions. So using, for example, community-based participatory research. So making sure we're asking the right questions and knowing the best way to answer them. Ensuring that we have leadership by communities which are most affected by inequality, so leadership within research, for example, and ensuring that we're recruiting a diverse sample of participants to our clinical trials so that we know that our drugs and our interventions work for everyone or don't work for everyone. And it's important we think about leadership in our decision-making boards as well. So, for example, making sure if it's a board that decides on policy, making sure that these boards are diverse and reflect the patient population. And the reason we need diverse voices on these boards are to better understand what we don't know, we don't know, essentially. So in conclusion, I think it's really important to realize that health inequalities are not fixed. They can be addressed, although it can seem hard. I think evidence shows that that a comprehensive approach is needed across multiple fronts. So we need to have collaboration between sectors and not just health and social care. We need research to really understand the barriers to care for certain groups and to provide an evidence base on what works. And there should also be meaningful involvement of the patient community, with those most affected by inequalities at the centre of the response. And finally, policy and service development should be assessed for any impact it has on equity at both a national and a local level. And I think just to end, to say health inequalities are everyone's problem. So if we're providing the best care that we can for the most marginalised groups in our society, then we're providing the best care for everyone. So I'm going to end there, and there's my contact details. I look forward to the Q&A.
Thank you very much. That was a lovely talk summarising everything that's continuing in the area. I'm afraid we're still having a few technical issues, and I don't think Kate Bramman's able to join us at the moment. And I believe there's a number of attendees that also unfortunately can't join us. What Paul Cockwell has suggested is that we carry on, but perhaps arrange another date where everybody will be able to attend. But as we've got a good 50 people in anyway, we will continue as we are. So we're going to move straight on rather than doing the Q&A session at the moment onto my my talk on KFRE, if that's okay with everyone. I'm hoping you can, although we've got technical issues with people joining, you can still post on the Q&A part. If you can't, I'm sorry, Karen is just typing to me. Oh yeah, it is a very slow connection, unfortunately. So I will move. I'm hoping that doesn't mean there's been an issue with the people viewing the slides as well. But I'm going to start my talk, and hopefully a few more people will be able to join us. We're up to about 50 people now. Okay, so I'm just going to bring my screen up. So hopefully everybody can see that. And as I explained at the beginning of the webinar, I'm Dr. Rupert Major from University Hospital Leicester and University of Leicester. I'm going to be talking today about the kidney failure risk equation and the new CKD referral pathway that was published at the end of August. So many of you will be already very familiar with this around the referral criteria, and actually within the NICE guidelines, not much has really changed since 2014, and I think there's a total of 8 criteria, and 7 out of those 8 haven't changed. The important things that have really been emphasized is when talking about referral for patients into secondary care from primary care, is talking to patients about what they taking into account their wishes and comorbidities in the referral. And the biggest change is really the use of this new prediction tool, the kidney failure risk equation. And the current guidelines is for considering referral for anybody who has a more than 5% risk of needing renal replacement therapy, dialysis, or needing a kidney transplant in the next 5 years. But also equally importantly, if you go a couple of paragraphs further back in the CKD new guidelines, you go back to the risk assessment section, which is entirely new, and clearly with a tool that is potentially going to predict the risk of people developing end-stage kidney disease. One of the things we have to consider is actually how we present risk to patients. And we're moving from talking about percentage kidney function with eGFR and the level of protein in the urine to an actual percentage risk. And NICE has published some very useful guidance on shared decision-making around communicating risk. And again, the points they emphasize is not using jargon-free, is using jargon-free language to communicate risk, and specifically trying to set aside time in the consultation to talk about risk as well. So what is the kidney failure risk equation? Well, it was developed in a multinational CKD cohort by Navdeep Tangri in Manitoba in Canada, working with the CKD Prognosis Consortium data, which you'll probably be very familiar with amongst other things in the various international and national guidelines, talking about the different risk going up of cardiovascular events, end-stage kidney disease and mortality risk going up as your CKD progresses. And you'll be very familiar with the traffic light charts, which are red, green, and yellow showing the different changes in risk. And they developed two different forms of the equation, looking at risk prediction in North America and then also in non-North American populations. And as I've alluded to, it predicts risk for the need for dialysis or transplantation, in other words, end-stage kidney disease, in the next 2 or 5 years. And the NICE guidelines are really focused on the 5-year time frame. And they've recommended it for use based on some work we did in Leicester and the East Midlands that actually looked at adjusting the KFRE for UK primary care. So our original study looked at just over 35,000 individuals with CKD based in East Midlands primary care, just over 400 cases of end-stage kidney disease over 5 years of follow-up. And it showed that the tool had excellent ability to identify end-stage kidney disease, in other words, very good statistical discrimination. But it did need some adjustment for risk prediction in the UK, and that's called recalibration. And again, that's very, very common with most risk prediction tools, and it happens in other tools you may be familiar with, like the QRIS-3 score that's used for cardiovascular events. So what is the KFRE based on? Well, it's based on 4 variables, 4 different pieces of information. The first one being the age of the patient, the second one being the patient's gender, the third one being CKD epi EGFR, and the final one being urine ACR. All things that are, generally speaking, usually relatively available to us as clinicians, both in primary and secondary care. So how has the CKD referral pathway developed? Well, sometimes we get asked the question, or I get asked the question, why did you choose 5% in 5 years for this new criteria? If people are a bit less charitable, they might say, well, that's a bit low, isn't it? Shouldn't it be at least 10%? And finally, if somebody's feeling particularly unkind, they're going to say to me, we're going to get loads more referrals and you've created a lot more work for us in secondary care for this issue. And we're unlikely to see any benefit is what they follow that up with. So why have we gone for 5% in 5 years? What's the rationale behind that? So as part of the study that I mentioned earlier, we looked at a sub-cohort of just nearly 16,000 individuals who weren't known to secondary care kidney services at the time of the study. And of those individuals, 89 developed end-stage kidney disease in the next 5 years. And so what we did was we looked at what would happen under the 2014 NICE criteria. In other words, the main criteria for referral being an EGFR of less than 30 or an ACR of more than 70. And what we found was of that population, about 880 people were potentially eligible for referral. And of the 89 cases, 41 cases of end-stage kidney disease weren't referred at the initial point. In other words, they're cases that we were potentially delaying referral to, who subsequently went on to develop end-stage kidney disease. So then we looked at KFRE criteria alone. And one of the things we wanted to look at was particularly around previously suggested criteria. And we'd found from Canadian literature that 3%, 5% and 15% risk had all been looked at previously for various different referral reasons. What we found was if we had used a more than 3% criteria, that would have increased referral eligibility by nearly a quarter, but we wouldn't have detected any new extra cases of end-stage kidney disease. If we looked at the more than 5% criteria, it actually looked that it might decrease referrals by nearly a third and actually detect some further cases that weren't referred. We also looked at 4% as well, just to look at the in-between area, and actually we got very, very similar results to the already existing NICE criteria. So what we realized from that was actually looking at KFRE criteria alone wouldn't actually be any better than the current NICE criteria. But instead, we looked at hybrid criteria. So by that, I mean, we looked at suggesting referral either an EGFR of less than 30 or a KFRE risk greater than 5%, or an ACR greater than 70 or a KFRE greater than 5%. And what we found for the EGFR hybrid criteria was that actually, although there was a 10% reduction in referrals, we were missing additional cases of end-stage kidney disease and potentially delaying referrals. When we looked at the ACR hybrid criteria, we found that actually there was still a small reduction in referrals, and we also detected additional cases of end-stage kidney disease at an earlier stage, meaning that referral might be made at an earlier date. So coming on to the second question, why not 10%? Well, if we imagine an individual, a 70-year-old woman, for instance, with an eGFR of 19 and an ACR of 2, somebody who we might see fairly regularly at the moment in the kidney clinic or have a referral from a GP about. Well, actually, their 5-year KFRE risk is just under 9%. But as we all know, and for the nephrologist, I probably don't need to re-emphasize, the risk of non-end-stage kidney disease, CKD complications, then become an issue. So for instance, looking at this data again from the CKD Prognosis Consortium, parathyroid hormone particularly, and secondary hyperparathyroidism starts to rise, particularly as you get down to an eGFR of certainly less than 25, and if not less than 20, it's significantly raised. And so if we raise the threshold for referral, we would either start to miss these cases of complications that aren't related to end-stage kidney disease, or we would have to accept that we were going to see them at a later stage with those complications already established. So we have this new tool, but clearly there's potential barriers to the CKD referral pathway with this new criteria. Anything new? I'm sure many people remember the introduction of eGFR and what happened potentially around that, the increase in referrals with that. So what are the potential barriers? Well, actually, one of the issues is going to be the availability of data to calculate KFRE, and particularly in relation to urine ACR and particularly in patients without diabetes. So this is a very useful chart from the CKD national audit, and essentially shows that primary care is actually very good at checking eGFR on an annual basis. 85% of people with diabetes have it checked. 95% of people with high blood pressure have it checked. But where there's less data available is in relation to urine tests. So only about 50% of patients with diabetes have their ACR checked on an annual basis, and clearly that's a big barrier to calculating KFRE. We also know there's going to be issues about integrating it into calculations into systems, and that will either probably take place either at the laboratory level in the same way that eGFR is calculated, or within electronic healthcare records, particularly in primary care. Clearly, one further limitation of the KFRE is in relation to the variables that are put into the calculation, and therefore the limitations of KFRE are very similar to the limitations of eGFR and ACR. And I probably don't have time to go into the full details about both of those, but just bear that in mind when you're using it. And there perhaps is going to be some confusion regarding external websites, and I've deliberately not cited any of them because they will give you the results of the previously calculated non-North American KFRE and not the UK calibrated one. And finally, one of the fundamental questions clearly is, does it change outcomes for patients in the long term? So that's the end of the introduction to the KFRE. And just to highlight a couple of things, that we do have a UKKA working group on KFRE implementation. And this is aiming to support people implementing it and supporting research and policy. And we're particularly welcome to anybody joining us, and particularly in relation to any patients wishing to join us. And I've noticed there are some patient representatives on the call tonight, but also primary care professionals as well. And again, to highlight the UK Kidney Week Symposium on KFRE implementation that's on the Tuesday in the mid-afternoon. I hope to see some of you there and to hear from you about your thoughts on the KFRE and implementation. So thank you very much. So I'm going to now, whilst I was talking, Paul has appeared. So I will stand back and let him take up his important role chairing the session.
I'm Karen as well. Yeah, we're really sorry, everybody. Hi. So we've actually, as Rupert and Ragesh, we've been talking, and people have been trying to get on. We sent out a Twitter and an email saying that we'll run this shortened session, and Rupert and Rageshri and Rajib have been fantastic, I'm sure, in managing the session on the hoof. But we will put this back in as a full session because we suspect that there's a number of people who'd registered who's not been able to get on, because we know the number of people who were trying to get on were delayed in getting on for different reasons. And we're still missing 2 of our faculty. So Kate Brannan's not been able to get on, neither has Dorothy and Nick. So we're not able to talk in detail about that really important change around the removal of the recommendation that there's an ethnicity adjustment around EGFR, but Rageshri's will have spoken about the broader context. So what we'll do from this point on is bring Rajib in, and then we'll have a Q&A around what's been discussed on the webinar, but also we'll pick up any other aspects that people want to discuss as well. So I can see some questions are coming through on the right-hand side. So do put your questions in, and we'll try and deal with those at the end of Rajib's presentation. The only other thing I probably would signpost, Rupert may have done this anyway, is that this is a major update in the chronic kidney disease guideline. And remember that it's not just an update of the CKD guideline, which I think was last updated in 2014, but it also brings into the document the anemia and chronic kidney disease guideline. It brings in hyperphosphatemia in CKD 4 and 5, and it also brings in guidance for children and young people. And we know that the guideline has a fundamental influence on the way that we practice down the chronic kidney disease pathway. And it's very important for us to reflect on this and think about what we collectively need to do to enable it. So we'll run this again, but run it in a more extended way and look to bring in some of the other components also. So it's a great pleasure to ask Rajib Pal to come in. Rajib's a general practitioner in Solihull, who's very well known in terms of his long-term involvement in a number of areas in kidney disease. And Rajib's been a NICE chronic kidney disease guideline committee member, and is going to just signpost us in terms of thinking around the NICE CKD guideline from a primary care perspective, which of course is where a lot of the implementation of chronic kidney disease care occurs. Rajib.
Thanks, Paul. Thanks for the introduction. I'm afraid my camera is not working for some reason, even though I logged in through my mobile for the camera, but I think you can all see my screen share. Can everyone see the slides?
Yes, I can.
Yeah.
Okay, brilliant. Okay, so thanks for the invite, Paul. So I'm going to be talking about working with primary care to implement the NICE CKD guidelines, and it follows on nicely from the earlier presentation about the change in guidance, the referral criteria, and more specifically the equation and the thresholds for referral. So my background, as Paul's mentioned, I'm a general practitioner and I've got a specialist interest in kidney disease, and I've been involved with several guideline groups and committees and redesign of pathways and primary secondary care interface. So looking at NICE CKD guidelines, what has actually changed? And actually, if you look at the NICE guidelines, not a lot has changed. A lot of the guidance is still very, very similar. I think so what I've done in this presentation is picked up a few key things where the referral criteria or the thresholds have changed. The first thing is one of the referral criteria is at what level of GFR should primary care be considering a referral? And there's a couple of things here. And the first thing is about a drop in GFR of 25% or more and a change in EGFR category within 12 months. And I think this is very, very important because if we go back to the olden days of the CKD guidance, I think people were talking about referral with a drop in GFR of 5 or 10 mils. And again, we all know the GFR variability is huge, especially within the normal levels of GFR. It can vary quite a lot, and the variability factor can be 20–30% sometimes, especially in the relatively normal ranges. The other thing is particularly useful is if there's a decrease in GFR of 15 mils per minute over the last 12 months. And I think this probably puts it more in context as to what sort of numbers we're looking at. in terms of referral from primary care, so that there isn't, unnecessary flooding of referrals into secondary care, where it might have been mild dehydration or an intercurrent illness and things like that. However, NICE does make
can we just hold you for a second, Rajib? Your slides are frozen on your first slides.
Have they? Okay.
Yeah, I think if you've got a presentation, then you should then be able to move them forward.
Let me try again, Paul. Just a second. Can you see the next slide?
No.
I think the slides are frozen. I think I've emailed the slide to Sarah. I don't know whether it would be better for her to, if it's possible, to share it.
Yeah,
and
I'll bring them up. Okay,
sorry about that. I'll just come out. That's great. Thank you. Okay, so I've touched on this already about the thresholds for referral with a decrease in GFR of 15 or a persistent change in GFR of 25% and a change in GFR category. And I think this is more relevant because, like I said, earlier guidance talked about 5 mils per year or 10 mils per year. And again, with the huge fluctuations in GFR, this was causing a lot of problems in primary care and potential inappropriate referrals into secondary care. But I think we've come a long way since then. And I think most of us in primary care have got the feel that what we're interested in is the trend in GFRs rather than an isolated reading. So I think this guidance from NICE is particularly helpful, where it actually specifies the 15 mils per year or the sustained change in GFR. However, the good thing is NICE does make it very clear that if there is a new GFR which is low, and we haven't got old readings to compare it with, it is imperative that primary care does repeat it in a couple of weeks to make sure that this is still chronic kidney disease and this isn't evolving acute kidney injury. And I think that is still a message we do need to convey to primary care. Next slide, please. Thank you. So the other change in referral criteria or threshold is the use of the 5-year risk equation, 5-year risk of needing renal replacement therapy of greater than 5%, which has already been discussed earlier. And this is using the 4 variable kidney failure risk equation. And again, some of us have used this in the past, but again, it's useful coming from NICE. And again, it's interesting that it's one of the referral criteria from NICE, where primary care should be referring into secondary care. And at the risk of duplicating what's already been mentioned earlier, that there's obviously pros and cons as to why the threshold's been set at 5%. And the idea is to pick up the appropriate number of additional cases of potential end-stage kidney disease patients, where we can actually make a difference to the outcome. Okay, next slide, please. So this is the kidney failure risk equation and the link there. And as again, it's been highlighted before, the 4 variables, age, sex, GFR, and the urine ACR ratio. And if the patient is a UK resident. And again, most of these demographics are easily available when patients are sent for blood tests. So age and sex, yes, the GFR is obviously being processed by the lab. The urine ACR might be available at the lab level or at the primary care level. But really, what we're looking at is maybe some sort of a system where there's a calculator built into the primary care IT systems or the lab system, which actually generates the KFRE value, so that when it comes back to primary care, it's actually a bit like the QRISK-2 score for statins. And it's so much easier then for primary care to make that decision as to who needs to be referred. But I think we are some way at this stage of having that implemented at either a lab level or at primary care IT systems level. Okay, next slide, please. And again, this I don't think is a new referral criteria, but just to stress the importance of proteinuria, which I think we're all familiar with. And obviously GFR is important, but what is vitally important is not to forget the proteinuria referral thresholds. And again, NICE makes it very clear that if the ACR is more than 70, essentially we should be considering at least a discussion or a referral to the nephrologist, unless of course there's an obvious cause such as diabetes, and that clearly needs appropriate treatment and management first to see if the ACR, if the proteinuria levels can be improved, and the lower threshold for referral if there is presence of blood along with proteinuria. So again, these are messages that need to be conveyed to primary care, along with the other referral criteria, which is similar to previous, along with the KFRE equation, so that the appropriate cohort of patients can be referred into secondary care in a timely manner. Next slide, please. So what are the implications for primary care in terms of the updated CKD guidelines? And as with any NICE guidelines or any updates in guidelines, the first stage is education and awareness. Unfortunately, CKD is a very small proportion of work that we do in primary care. So, you know, there's guidelines coming out sort of every month from different areas. So overall, it's relatively small area of work, but it is important that an important area such as this, there's education and awareness for primary care. And this can be done at a practice level or at a primary care network level or a CCG level. And using different methods of communication, whether it's emails, short videos, webinars, CCG, protected learning time events, etc. Interface working and support is vitally important, and I think Paul knows this very well. We've you know, have been involved quite closely with his trust for a number of years in looking at implementation of EGFRs, redesign of CKD pathways, some work in AKI. So again, interface working and support is very important. We mustn't forget the patients, patient information and education. I think our patients are going to be asking, you know, why are you referring me? You know, my blood tests are okay. It's not that bad. My GP's told me, you know, it's been okay 6 months ago. And suddenly you're referring me because the KFRE is more than 5%. What does it mean for me? So I think it's vitally important. I think it's taken us a long time to explain risk to patients. For instance, you know, what does a high Q-risk score mean? And why does the patient need statins? And I think even now we struggle sometimes about communicating risk. So again, there's a lot of work that needs to be done with patients, a lot of information, a lot of education levels. What we don't want to do is we don't want to scare patients off, but equally it's important to risk stratify patients. Who's the patient we're worried about who might develop kidney failure? And what difference does it make if we pick this patient up early? Obviously, there's a huge difference in terms of prognosis, you know, reducing risk of patients suddenly ending up on dialysis. So it's particularly important. I've already touched on this about laboratory reporting of risk scores, and I gather there is work in progress at the moment. I mean, some of the parameters are already available, such as the age and sex, and obviously the GFR from the blood test. And I don't know if systems can be integrated where the last urine ACR, maybe within the last 3 months or 6 months, could be incorporated to calculate a value for the risk scores, which would be immensely helpful for primary care. And last but not the least, referral pathways that are compatible, that's reasonable for both primary and secondary care, so that we don't burden secondary care with unnecessary inappropriate referrals, whilst we actually refer patients appropriately in a timely manner. So that's, again, you know, a lot of work to be done on all of these fronts. Next slide, please. So that's pretty much where we are from a primary care perspective at the moment. And again, I'm happy to take any questions.
Thanks very much, Rajiv. I suspect the questions that Karen and I may be missing some of the questions that have gone into the chat because we came on late, and I just worry that that is the case. Can I just ask Rupert to double check and pick up any earlier questions, and perhaps while we're doing that, ask if Rageshri, are you able to come on camera, Rageshri?
Yeah, I am.
Great. Perhaps Rageshri, if we start with you, Karen and I didn't hear your presentation, but we have heard you talk before about inequalities, and of course, you've put a lot out in the public domain and have written on this as well as talked about it in detail. If you're thinking about what a clinician does at the practical level, a healthcare professional who's working in kidney disease, in the consultation itself, how does one actually look out for challenges within a consultation in terms of inequalities? What's the top line for you? How can we be sensitive to that? How can we manage our unconscious biases in terms of our interface with the patient, etc.?
So that's a really good question. So I think there's something about really being aware of the power imbalance in the room. And I think about this quite a lot. So for example, my mum is a retired GP. So she's someone very used to working in the NHS and being part of the NHS. But for her, when she sees her GP now, she'll still get dressed up for her consultation because she wants to feel like she has the confidence to talk to her GP about what she needs to ask. So I think there's something about making sure that we're aware and thinking about how we can reduce that power imbalance. I think it's really important to think about what are the structural issues that surround the patient. So what are the things outside of clinic which affect them, which impact on their ability, for example, to carry out healthy behaviors, like, for example, try and eat well, try and exercise, stop smoking. What is it about their life that are causing those kind of more structural barriers? And when we do that, when we think about the barriers that are outside of clinic, it can help us understand why patients don't always do what we ask them to do. And that means that it leads away from that kind of more blaming approach. So blaming the patient for some of their behaviors to an approach which patients understand as being more open. It means that you can have more open discussions with your patient and that they can tell you their concerns, which can then be addressed. So I think there's something about the holistic thing of understanding what's going on in their lives before they get to clinic and outside of clinic, and for us being aware that we have bias, that there are power imbalances in the room. And I think it's not just individual as well. I mean, what policies can we put into our services, which means that we overcome individual bias? So I mentioned it in my presentation. There are policies, for example, pro formas, which mean that, you know, you're asking everyone the same questions, for example, if they're new patients. And as I said, in HIV, we now encourage opt-out HIV testing so that no one's making the individual decision of, does this patient have HIV? So that's just some things to start off with.
Okay, thanks ever so much for Gestry. And I can see that you've answered, I think Charlie Thompson's put a question around recruitment for research studies, and you've put a written answer in for that, which I'm sure people can read. Is there anything else you want to say about that while we're on that subject at all?
So I think it's really important to think about the research gap. So when we think outside of renal care, we think about medicine in general, there's a huge gender research gap, for example. So there's very little money that's been put in the past to look at what's seen as women's health issues and sexual and reproductive health. So really thinking about where the voices are in terms of in the funding bodies for research, who decides what research is important, who is then asked to carry out the research, is that research being led by people from some of those communities? And that's really important because it means that we can ask the right questions and do it in the right way. And then that leads on to kind of participation in terms of who is recruited in clinical trials. It means the research team is better able to think about the barriers and incentives for people to take part in research. And it means we have more diversity.
Thanks very much, Gestry. And of course, one of the major components of the webinar was going to be on the ethnicity adjustment, or the removal of the recommendation for ethnicity adjustment for EGFR for people of Black ethnicity or Black race. And there's a lot of discussion in that phrase itself around terminology that we use. And what we'll do is we will come back to that in a second follow-up webinar, because Kate Bram's given that a lot of thought, and there are other people as well who would have contributed at a panel level in terms of discussion around that. That's going to be a major area for us collectively to think about how we bring that change through into practice. But we'll put that to one side because it's going to demand a lot more than a little bit of informal discussion time. Perhaps the thing for us to do now is to think a little bit about KFRE, and of course that in itself could expose substantial inequalities. We've got concerns, or we've had concerns long-standing, around the thresholds for referral from primary to secondary care, and the development of kidney failure risk equation, as Rupert has said, addresses a number of those issues, but there are substantial things that we need to do before we get the greatest value from KFRE. There's a technical question from Charlie Thompson, Rupert, around calculation and calibration without the ethnicity factor. Do you want to say something about that?
Yeah, thanks for your question. Thanks for your question, Charlie. Yes, it's a really good point. I think there's a few points to make around this, which is, as I alluded to, the original KFRE development in 2016 mainly looked at North American populations, where clearly there was the split between white and black ethnicities, is how they presented it in the paper. They didn't do any analysis looking at that at the time. I'm not aware there's any plans for them to do that, although we could easily ask that question. There are some papers under peer review looking at the question. I don't think we've got a definitive answer to that. I think some of it looks at the eligibility around transplantation and whether specifically using KFRE criteria is the case. So that's really North American data. For the UK, I think for our study, we didn't present any ethnicity data at the time. We certainly, in terms of people of using the black ethnicity correction, we didn't have sufficient numbers to look into that question. We did use the ethnicity adjustment within the analysis, so it's sort of bound up within all the other information. We have submitted a sub-analysis for people of South Asian ethnicity, which is we at the Kidney Week coming up in October, and I don't want to give the full results away, but it does look as if KFRE actually underestimates risk. So that's quite concerning. Actually, it means potentially individuals may have a delay in their referral if they're using KFRE. We can do some corrections for that on EGFR. I don't think it's a brilliant correction because it's not been fully validated in the UK population. I believe when Paul and his team looked at the recent KI reports paper using CPRD, even though they were using sort of several 100,000 individuals, the ethnicity breakdown away from the white ethnic group was fairly small and probably not able to answer that question. So there's certainly plenty of work to do on KFRE in this area.
Yeah, thanks, Roop. And so there's a lot of work to do in terms of enhancing the accuracy of the equation for the UK population. I guess, and perhaps Raji could come in here. There's a lot of care that we need to take around the implementation. And before Raji says something about that, we're trying to systematically engage across healthcare professionals in terms of helping people understand KFRE. And I think that all of you who are working within chronic kidney disease systems would be giving that some thought. We're hoping to get some education modules out that support around KFRE that you can use across primary and secondary care in terms of bringing healthcare professionals up to speed with it. And one fundamental question, Rajiv, is how does one integrate at a system level from a primary care perspective? I think Rupert's been talking to System 1. Also, there are some discussions developing with EMIS where you have risk calculators embedded within the primary care systems. Rajiv, how does that function? Are they powerful? Are healthcare professionals in primary care using them?
Yeah.
Are they built in a way that provides alerts at an individual patient level?
Mm-hmm. Okay. Yes, I mean there are some risk calculators that's built into the system. The common one that's used is the QRISK2 calculator that I mentioned to determine the 10-year risk of cardiovascular disease and eligibility for statins. But that's taken a long time to be established and embedded in the system, where we can click a button and basically the GPIT systems basically calculate the QRISK2 score for us. There are also simpler calculators like SHATS2, VASC2 score for risk of stroke and atrial fibrillation. And there are more tools like cancer detection tools, risk stratification tools. Those are not so well embedded in the system, but the ones that are commonly used are things like the QRISK2 score. Now, with the KFRE, because it's the parameters are fairly basic, so age, sex, GFR, and ACR, it should be fairly easy to sort of interpret in that sense. But I think the practical issue is, unless there is a number which the primary care team can click a button and you get the risk score, I think it's going to be very difficult for clinicians to sit down and work out KFRE for all the GFRs that you're doing on a daily basis. So I think there is definitely, the way forward has to be integration with IT systems such as EMIS, System 1, Vision, all of these things. And I think only once we're convinced that that is possible, then I think we should proceed with the education so that, you know, primary care can refer appropriately through pathways.
Thanks. Yeah, thanks very much, Rajiv. Perhaps we explore a couple of additional things. So Charlie put in a comment about, which is $6 million comment, isn't it, about the measurement of albumin-creatinine ratio. And actually, I mean, one really strong argument for KFRE, of course, is that KFRE provides impetus for albumin-creatinine ratio measurement. My view is that the other thing that really drives the centrality of albumin-creatinine ratio measurement is that many of our interventions now are ACR based. ACE inhibition and angiotensin receptor blockade is ACR based when one looks at the benefits for risk of progression of kidney disease. And of course, the large amount of impressive data that's coming through on SGLT2 inhibitors is ACR based. And one of the really important recommendations in the NICE guideline is around the use of SGLT2 inhibitors, and is specifically talking about diabetes and the threshold of an albumin-creatinine ratio of 30 milligram per millimole. Now that of course relates to the CREDENCE study, which is the canagliflozin study, but we also, of course, have a substantial amount of evidence now from non-diabetic chronic kidney disease, particularly through CKD, and dapagliflozin has been licensed for non-diabetic chronic kidney disease. And just a signpost here for you all is to have a look at the SGLT2 inhibitor draft guideline document that's gone out for consultation. I think the consultation is still open. That's a real tour de force. So that centrality of albumin-creatinine ratio testing. Dorothea was supposed to be on the panel, but couldn't get in. And if Dorothea was on the panel, she led the national CKD audit, she would be jumping around and reinforcing Charlie's comments that only 20 to 30% of people outside of diabetes are having albumin-creatinine ratio measured on a regular basis, consistent with the recommendations of the NICE guideline. Can I bring Karen in and just ask Karen for her thoughts on this transition that we've got from kidney failure risk equation, from EGFR-based thresholds to kidney failure risk equation, because of course that goes right down the pathway, doesn't it? Right down to end-stage kidney disease. We used to talk in, healthcare professionals, we used to talking about, EGFR is less than 50 mil per minute, that people need to be activated for listening for kidney transplantation, etc. The EGFR threshold of 30 mil per minute has gone from the NICE guideline now, and has been replaced by the 5% and 5-year threshold. What are your thoughts on that? How do you think we need to work to bring everybody onto the same page with this?
Yeah, I think that's a really good point, Paul, because we're so used to, I think, looking at those thresholds and also extrapolating those to percentages of kidney function when we're talking to our patients and explaining what that means. And I think, we've been so used to those figures for quite a long time. Now switching across to risk factors, I think your point about education is going to be absolutely key, particularly, I think, for staff working in advanced kidney care clinics. Patients are being referred in, and we're looking at their risk factors or their risk levels as opposed to their other thresholds for triggering for workup for transplant or when we do vaccinations, etc. So I think there's quite a lot of explanation in there for the multi-professional team, and looking at, bringing in other professions such as the dietitians when that's going to be a trigger for starting different treatments and things. And I think thinking about how we're going to be passing that information across to patients. I mean, obviously we've got Fiona on the call, has probably got some questions, but if somebody's got a rapidly changing kidney function, which we're monitoring and we're looking at those thresholds, and we think, yes, we get to a trigger point for starting dialysis, then that actually might be much faster than trying to do the risk assessments the whole time. So I think there's a lot of information in there to process, and it's getting those clear messages across, I think, to the wider team and across from primary to secondary care. It's not, you know, our whole referral criteria at the moment is based on somebody's GFR less than 30. So it's going to be a big sea of change on how we look locally at our referral criteria and our guidelines, I think. So that's what I'd be thinking around that.
Thanks, Karen. That's and of course we're really challenged because we've got so much to take on in so many areas at the moment. But if you look at a population level, of course, it's down that chronic kidney disease pathway that we've got the most opportunity to do the most good for the largest number of people. There's quite a lot of discussion going on around thresholds of KFRE for people with more advanced chronic kidney disease, I think, Rupert, with people starting to think about perhaps a threshold KFRE of 20% at 2 years for people going into a multi-professional team advanced kidney care clinic and starting counselling for modality choice, and then a threshold of 40% at 2 years perhaps for formation of an arteriovenous fistula for people who elect for hemodialysis as mortality, and a threshold of 40% also perhaps for listed for kidney transplantation. There's a lot of work that needs to be done, particularly around that area of kidney transplantation timing, because we know there's a huge variation across the country in terms of the listing of patients pre-dialysis for kidney transplantation. So this is opening up a whole load of really important opportunities and important quality improvement issues. Andrew's put a comment here, Andrew Frankel. Thanks, Andrew. Andrew's with James Burton led on the SGLT2 inhibitor guideline, which is really a sort of which is a stunning piece of work. And that rapidly changing GFR, Rupert, we have to be careful with this. Karen talked about it as well. And some of this, I guess, is around reusing our clinical decision systems in the right way and getting KFRE integrated in there. Have you got any comments on that at all?
I think, as I mentioned in my talk, I would treat KFRE with the same limitations that you would do around ACR and EGFR. And we all know that we shouldn't be using it in the context of certainly acute kidney injury and rapidly non-steady states of serum creatinine. So I do think that is a limitation. There is ongoing research work for it. I was just posting a reply to the question in the chat, but the data from CKD Prognosis Consortium is certainly suggesting that adding in sloping change in EGFR on a population level doesn't add predictive benefit. It doesn't improve prediction. That's not to say, however, that is not the case at an individual level. I think with some of these statistical tools that assess prediction, changes to a small number of individuals are often drowned out by the wider results. So it's important to again use clinical acumen that if somebody's EGFR is rapidly declining, KFRE will underestimate the risk, and that's again as Rajib was saying, that's why there's still the other criteria there. That's still the reason why there's the ACR threshold. That's still the reason why there's the 25% EGFR change threshold, because it's KFRE is important, but it's not the only criteria.
Thanks very much, Rube. I guess we're at 6 o'clock. So despite the fact that we've had a little bit of a sort of unusual webinar, we still extended, we're still taking the time available to us because there is so much to discuss. Can I just ask Karen if there's anything that you think we need to discuss, further pick up around what we've been chatting about over the last 10, 15 minutes or so? We've covered a reasonable amount of ground.
No, I think we've covered most sort of topics that have been in the chat and that people are asking questions about. But I think there's obviously more which we haven't been able to present this evening around the ethnicity question, and I think that's and the adjustment, taking that out, the adjustment of the EGFR, and there's probably, as you said earlier, other aspects from the NICE guidance we need to be taking forward. So I think we probably sort of summarise where we are with things for tonight, but I think going forward, perhaps then we can have another webinar where we can have those extra things put in as well. So I think we're probably
definitely.
okay.
Yeah, definitely. So what we'll do is we'll schedule a second webinar on the CKD guideline to happen within the next 2 to 4 weeks, and we'll look at the story behind the removal of the ethnicity correction. There's been a large group of people, some of whom are on this call, who've done fabulous work in terms of reaching a consensus across patient and professional organizations, and you've seen the statement that's gone out around that, which went out in association with a nice guideline update that was a couple of weeks back now. So we do need to spend some time on that. We need to be sure that we're supporting people around that change in recommendation, because there are fundamental issues for relatively large groups of people in terms of reclassification of kidney disease and indeed of therapeutic options. You know, that change, does it take people below the threshold, for example, for receiving chemotherapy for certain cancers? What does reclassification mean for people of Black ethnicity in practical terms? So we'll run another webinar where we focus on that, and perhaps we'll do that in combination with focusing on some of the therapeutic angles as well that are present in the CKD guide, and that may allow us to further explore optimal use of ACE inhibition, angiotensin receptor blockade, SGLT2 inhibitors, and perhaps something around hypertension as well. So there's lots to work on here, and then we need, of course, to think about how we use our resources to support improvement in implementation and education as much as possible. Okay. Well, thanks everybody. Thanks ever so much for your time in joining the webinar. And can I particularly thank Rupert, Rageshri, and Raji for being so adept and nimble at taking you guys through the first part of the webinar, while Karen and I sort of fumbled with the IT with 5 minutes to get on. Okay.
Thank you.
Thanks now.
That's been great.
Okay. Good night,
Thanks
everybody.
very much. Thank you.
Thank you, everyone. Bye-bye.
Bye.
Bye.